In the second half of the introduction, we are going to cover the factors affecting the rate of drug penetration through the skin and methods to achieve maximum drug penetration through the skin. But before we get into today's lesson, we need to understand that when we apply our semi-solid topical preparation to our skin, the drug follows three main sequences. It is released from the base of the topical preparation, it permeates and penetrates through the skin, which I have here represented in green, and then it will exert a pharmacological response and give its therapeutic effect. If we wanted to control the rate at which the drug penetrates through the skin, we would first need to know the factors that affect the drug penetration. Number one is drug concentration. The drug concentration should be high in the base and low in the skin to facilitate passive diffusion. Passive diffusion is a type of simple diffusion, as we know, and simple diffusion in this case is the movement of drug molecules from an area of high drug concentration to that of a lower drug concentration. The second factor is aqueous solubility of the drug in the base. So there's always a balance with things. It's not necessarily all absolute. The aim isn't for our drug to be completely soluble in the base, because if it was, it wouldn't move towards the skin. Likewise, the drug should also be soluble to some extent to avoid phase separation. So we want the aqueous solubility of our drug to be somewhere in between. It should be soluble to avoid phase separation, but not too soluble so that it can still penetrate the skin. Third is the partition coefficient of the drug between the stratum corneum and the base. The stratum corneum and the base will therefore act as our two phases. And the partition coefficient of the drug is a very important concept. When our drug leaves the base to penetrate the skin, it isn't actually leaving it. It's distributed between the base and the skin, and this is what we call the partition coefficient. However, we don't want it to be equally distributed between the two phases. Our aim is for the drug to partition itself more towards the skin, since the skin is the target site which the drug will exert its therapeutic effect on. And therefore, we can establish that the partition coefficient is inversely proportional to the solubility of the drug in the base. The fourth property is properties of the vehicle. So just like the properties of the drug is important, the properties of our base is also important. There is this general rule that we need to know in pharmaceutics, being like dissolves like. This refers to the nature of the compound that dissolves in a given solvent, and therefore we usually talk about it when we're talking about solutions and solubility. Polar compounds are soluble in polar solvents, and non-polar compounds are soluble in non-polar solvents, and they need to be of the same nature, polar with polar and non-polar with non-polar. So why am I even talking about solvents when I just said a few minutes ago that our drug partitions itself between the two phases and isn't dissolved? Well, that's precisely why. It's because we need our drug to be soluble only to a certain extent, which will allow us to avoid phase separation, but at the same time to allow it to partition itself. And therefore, this general rule that I just gave you helps us establish that our drug must be of different nature than the base so that partitioning can happen. So we talked about the drug's properties and the base's properties, but what about the skin? If the epidermis is present, that means that our skin is normal and intact, and upon application to the skin, the drug would need to pass the 4 layers of the epidermis to exert its effect. If our skin is not healthy, for example, it's dry, bruised, or burned, drug absorption would be abnormal. Note that when I say dry skin, I mean severely dry skin. The cracks and bleeds due to a lack of moisture retained in the stratum corneum, okay? If the skin is open due to cuts or wounds, like the diagram that I have right in front of you, That means that the structure of the epidermis is disrupted, making it easier for the drug to penetrate to the deeper layers, as there's no longer those organized layers that it would have to pass through. That also tells us that when giving the patient with cut skin a topical medication to apply to the cut region, it will absorb more of the medication than with intact skin. Therefore, we can establish that the dose of the drug given to a patient with intact skin will be different to one with cut skin, and hence, a patient with cut skin will require a dose lower than the therapeutic dose to exert the same effect. This is a summary of what we just discussed. We said that the rate of penetration of the drug depends on the drug itself. It also depends on the base and on the skin condition. Under the drug's concentration, aqueous solubility in the base, and partition coefficient. With the base, we said that it must be of different nature to the drug so that partitioning can happen. And depending on the skin condition, whether it is intact, abnormal, or open, the drug's penetration will be different. And we also need to know that the drug penetration in open skin or cut skin is the highest, because again, there is no longer that epidermal barrier layer which blocked it or which made penetration harder. Right. So there is this law which summarizes the factors affecting the rate of drug penetration through the skin, and it is called Fick's law. The law is dm over dt equals A multiplied by K multiplied by D multiplied by C node over H. And most of the factors that we just talked about are mentioned in this law. dm is the amount of drug that diffuses from the vehicle to the skin. dt is the change in the amount of drug that leaves the vehicle to penetrate the skin over time, so T is time. A is the surface area over which the drug will penetrate, and that being the skin. And the higher the surface area, the greater the amount of drug is absorbed. K is the partition coefficient. D is the diffusion coefficient, which is the rate of diffusion. And C node, or C0, is the initial concentration of the drug on the skin. And it's 0 because before we apply the topical preparation to our skin, the concentration of the drug on our skin is 0 because we haven't applied it. And therefore, it will always be 0 before we apply it. And finally, H is the membrane thickness, which is the condition of the skin, whether it is intact, cut, bruised, or dry, for example. And as the membrane thickness increases, the amount of drug that can penetrate the skin decreases. So overall, we can say that the rate of drug penetration depends on the amount of drug which diffuses over time to cover a certain surface area based on the partition coefficient of the drug. That will affect the drug's diffusion coefficient starting from concentration 0, affected by the thickness of the skin. Right. So there are 3 points we need to consider to achieve maximum drug penetration. Because at the end of the day, we want the topical preparation we're applying to our skin to be effective. We're not going to waste all that money in research and manufacture of a drug only for it to be perfect, except that it can't penetrate the skin, for example. The major composition of the stratum corneum is lipid, which favors lipophilic drugs. So it makes sense that since the primary interface between the drug and the skin is the stratum corneum, that the drug also be of the same nature as the stratum corneum, right? So if lipophilic drugs are favored, does that mean that we shouldn't formulate hydrophilic drugs? So all drugs in the market are lipophilic? No. So what's the solution? Well, if our drug is not lipophilic, we need to prepare it in its unionized form. Why in its unionized form? Because this is the form that is lipid soluble and therefore will more easily penetrate through the lipid content of the stratum corneum. That's the first kind of change that we can make to our drug. We also need to consider the intact skin. For a drug to passively diffuse across the layers of the skin, it's relatively more difficult than other routes of administration. And remember that we need to ensure maximum diffusion so that maximum drug penetration occurs, right? So, how can we do this? We can either change the pH of our drug, or we can add a co-solvent. Notice here that I said change and not increase, because depending on the changes that we make to the pH or the amount of co-solvent added, our drug's penetrating ability changes accordingly. Right, so change in pH. We established that we always want to prepare our drug in its unionized form, as that is the lipid-soluble form, which will penetrate most effectively through the stratum corneum. Okay, most drugs are either weak bases or weak acids, and we need to prepare them in their unionized form. It turns out that a drug will be unionized when placed in an environment of the same pH. So, if our drug is a weak base, we need to increase the pH of our preparation in order to give the drug the basic environment it needs to be in its unionized form. With the same logic, a weak acid will be in its unionized form when the pH of the preparation is decreased. That's the main concept we need to understand from this graph. By the way, this is a graph derived from the Henderson-Hasselbalch equation. Notice also that the drug, whether it is a base or an acid, becomes completely ionized at a pH above or below its pKa by 2 units, above or below. As we deviate from the pH at which our drug is most unionized, the drug becomes more ionized. Look, in both cases. Until the pH is equal to the pKa of the drug. At this point, the drug is 50% ionized. An important side note I want to mention is that we've been talking about changing the pH of the preparation, which we will casually apply to the skin. Sometimes people might be thinking, how do you apply an acidic preparation to your skin? Do you want me to burn my skin? Well, the stratum corneum is resistant to a certain extent to these pH alterations, withstanding a pH range from around 3 to 9 due to its nature as a natural buffer. So, ladies and gentlemen, don't worry about this at all. And finally, the co-solvent. We need to incorporate a co-solvent to our topical preparation as it enhances the solubility of the drug in the base to avoid phase separation. It ensures the drug is reasonably incorporated into the base, and it also ensures that the drug partitions itself more towards the skin. We also need to be careful that the partition coefficient of the drug should not oppose solubility of the drug in the solvent system. That means that we need to be careful when adding co-solvents to the preparation, because if we over-solubilize the drug, it won't be able to partition itself more towards the skin. Therefore, accurate calculations need to be done to determine the suitable quantity of co-solvent to be added. And with that, we finished the introduction to topical semi-solid dosage forms.